Chapter 8 Future Research Recommendations. Looking ahead, the scoliosis field needs a clear and practical research roadmap that puts patients first, and two goals rise to the top: running fair, long-term studies that compare modern physiotherapeutic scoliosis-specific exercises, or PSSE, plus metabolic care to spinal fusion, and building a standardized, mandatory registry that tracks every implant and every complication for decades, just as Drs. Weiss and Goodall urged in their 2008 review. First, consider the trial gap. Right now, surgeons often recommend fusion because they believe it offers faster curve control, while therapists promote PSSE because they see better flexibility and quality of life scores in the clinic. Both sides can point to small studies, but almost none of those studies are prospective, controlled, and long enough to cover the key years when teens grow the fastest and then step into early adulthood, where lifestyle choices and job demands test the spine in new ways. A gold standard trial would start with a large group of patients who all share similar ages, curve sizes, and risk factors. Researchers would randomly place half of the group into a PSSE plus metabolic program, one that blends exercises like Schroth breathing, balance drills, and a custom nutrient plan that boosts bone, collagen, and muscle strength, and place the other half into a state-of-the-art fusion pathway. Both groups would get equal attention, frequent checkups, and clear instructions, so the only real difference would be treatment type. The study would follow everyone for at least 10 years, measuring not just Cobb angles, but also lung function, pain levels, sports participation, mental health, and total medical costs. If the PSSE group matches or beats the fusion group in those areas, families would finally have high-quality proof that a non-surgical route can stand toe-to-toe with hardware. If fusion proves superior in certain cases, say curves over 80 degrees with rapid progression, then doctors could use that information to sharpen guidelines and protect the teens who truly need surgery while sparing others. To make sure the results apply to real life, researchers should recruit from many regions, include diverse ethnic and socioeconomic backgrounds, and publish an easy-to-read manual that other clinics can copy, so success does not rely on one superstar center alone. Second, a mandatory implant registry is just as urgent, because even the best trial cannot predict every future problem. Spinal hardware can break, loosen, or irritate nearby tissue years after the first operation. Yet today's records are scattered among private offices, hospital files, and patients who move or change insurance. A national or international registry would assign each implant a barcode, track the lot number, the surgeon, the hospital, and the exact position in the spine, then log every follow-up visit, including X-ray findings, pain scores, infections, and secondary surgeries. Whenever a rod snaps or a screw backs out, the event would be coded the same way, no matter where it happens, letting researchers spot patterns quickly. Is a certain alloy more likely to fatigue in athletes? Does a newer, low-profile screw cut revision rates in tall teens? Do flexible tether systems avoid adjacent segment disease or simply delay it? Without standardized data, these questions remain guesswork. Weiss and Goodall pointed out that reported complication rates swing wildly, from 0 to 89%, because authors choose different definitions and timeframes. A registry would end that chaos by forcing everyone to use identical checklists at set milestones, such as 6 months, 1 year, 5 years, 10 years, and beyond. The ethical payoff is huge. When parents weigh surgery, they deserve honest numbers about long-term safety, not the best-case snapshots that often appear in sales brochures. Creating a registry is no small task. It demands secure software, privacy safeguards, and steady funding. But other medical fields have already shown it can work. Hip and knee replacement databases in Sweden and Australia have slashed revision rates because surgeons can see, in near real time, which devices fail early and adjust their choices. Scoliosis care should settle for nothing less. The registry could also track non-surgical paths by logging PSSE session attendance, metabolic lab results, and diet or supplement plans, giving scientists an ocean of data to test new ideas, perhaps mixing exercise intensity with vitamin D status, or linking gene variants to breathing gains. To keep the project sustainable, device makers could pay a small fee per implant, governments could provide matching grants, and patient advocacy groups could help spread the word to ensure strong enrollment. In classrooms, medical students and physical therapy trainees could learn how to enter data correctly, turning accurate reporting into a habit from day one. Finally, the two goals, controlled trials and a registry, should not run on separate tracks. They should feed each other. Trial designers can use registry data to pick realistic sample sizes and key outcome measures, while registry managers can incorporate trial protocols to standardize assessments. Together, these efforts would move the field from opinion-driven debates to fact-based decisions, honoring the core principle that every adolescent deserves the safest path to a strong, flexible, and pain-free future. Until then, clinicians must keep sharing best practices, families must keep asking hard questions, and researchers must keep pushing for the big studies and honest databases that will light the way forward.